to set my tent up. This is Fraser Valley in Colorado. Notice the sky. There's no clouds. In the winter in Colorado, when there's no clouds, it gets what I consider really cold. So I got a little cold, but I thought I had the right gear. But I wanted to learn something. So I found this guy on YouTube so I could learn. This guy, in the span of 30 minutes, takes you through setting up a tent, putting a wood burning stove in there, measuring a carbon monoxide to make sure you're not killing yourself. And he also teaches you how to cook chicken Alfredo on the stove. And he doesn't say a single word. So I take that and I apply it to the fact, next time I do this, I'm gonna have some sort of stove. I bought a carbon monoxide sensor, I hung it up. I measured the inside temperature, the outside temperature. So I can tell you when I set this heater up, it's gonna be 17 degrees warmer in my tent than it is outside. I'm a circumstantial reader. My son is on the autism spectrum, so he does things and just read the catchy title. I have story after story after story after story. But this is, I walk into his room one day and he has taken his knife and thrown it into the wall multiple times. And then he writes his motivational verses on the wall. And so I'm thinking, I need to fix this, but I really don't want to hire someone to come do it because I'm kind of a nerd. So again, I learn how to take this $22 bottle of stuff and fix the wall. So now I don't have to pay someone $1,000 to do it. I'm a circumstantial learner. Bear with me as I go through this, because when I get to the top 10, you'll understand why I picked my top 10. A couple months ago, I get a phone call from a friend. He said, the cap to my hearing aid slipped off into my ear canal and I tried to get it out and I think I pushed it in further. The irony is the guy sells hearing aids for a living and tells people not to put anything in their ear. So being the guy that I am, I don't want him to spend $1,000 to go to the ER. I get my household tools and I then embark on this journey to get this thing out of his ear. Can you guys turn the volume up on that?
And he's an ear guy. The irony.
He's even showing my wife how to pull the ear out so I can see in there.
Aperture straight. There we go. Oh. Oh. Man. Push, push, push.
So I'm a circumstantial learner. I know how to learn. I know where to go to get the resources. I have an alter ego. My alter ego wears a uniform. And this is me standing next to my the commander in Djibouti in our train up. He just happened to become my battle buddy. His name is Jim Crow. But anyways, I put boots on the ground in Djibouti in 2019, and I spend most of the year there. And the first thing that the surgeon tells me when I get there is, guess what? You're in charge of the blood bank. I'm just a surgeon. What do you mean I'm in charge of the blood bank? What I also learned is the blood bank consisted of 90 units of glycerated frozen blood. They got to be kept at minus 60 degrees centigrade. So I began a consummate thing like, I got to learn how this stuff works. If I'm going to save lives, I got to learn how this stuff works. This is my first case there. I'm not a hand surgeon. This guy is the expert, the CB, the guy that's supposed to be a professional construction guy, and he comes in almost cutting his finger off. So I know where to go to get the information on how to safely take care of him. Realize I don't have to put tendons together. All I really have to do is wash it out and send them somewhere where they can fix it. I'm a circumstantial learner. This is a crew that came down from Germany. The person on the screen right, my left, is a pediatric gastroenterologist from Landstuhl Regional Medical Center. I get a phone call one day sitting at my office, and the person on the other end said, Jason, I need you to do me a favor. His name is Mike Weber. He's now the commander at Landstuhl Regional Medical Center, but he called me, and usually you don't use first names, but I was okay saying Mike. Okay, Mike, he was the AFRICOM surgeon, which is he worked for the 4-star general. And he said, Jason, I want you to bring virtual health to the continent of Africa for the Department of Defense. I'm sending 2 experts down to help you. This is before COVID. And I'm like, I don't know anything about virtual health, but I began to learn what our best practices, how can we deploy this in a theater, learning, talking, doing that. This is the first virtual health consultation on the continent of Africa. That's sitting at my desk. It took me 4 months to be able to plug that video camera into that computer without shutting the entire network down. That's the military for you. It took me 4 months to do that. So then I had this harebrained idea. I know the commander of the drone base. I wonder if he'd let me test like further downrange. So I took one of his laptops and we were able to successfully connect with Launch Tool from a downrange base, which is really cool because now we can connect the end service member back to the specialist and maybe prevent a transport. $65,000 every time we transported a service member from Djibouti to Launch Tool. If we had to get a charter flight, it was $290,000. So if we could prevent one of those a month, that's a tremendous saving to me who's paying taxes and you too. I get a call from one of our downrange people in Somalia. And I do another talk called The Tyranny of Distance. But my closest place that I supported was a 6-hour plane ride. It was the distance from Portland, Maine to Miami, Florida. So he called me and he called me on WhatsApp and he said, hey, I need you to look at this ultrasound. I have a guy with a testicular torsion. And so I'm like, holy cow. So I immediately learn, I go to YouTube and I find this Indian surgeon who's showing me how to do an orthopexy. I haven't done one since I was a resident, and I maybe didn't even do one then, but I know how to cut, I know how to sew, I know how to tie, I know how to use my brain. So this is where it gets a little, if you are uncomfortable, I apologize. But so we brought him here, and I actually did an orthopexy on the guy. You can see which testicle's out, but then I got to thinking, hey, I don't know if that right testicle looks normal, because I've never seen what like post-reduction looks like. And I've done this before. So I took an ultrasound.
Okay, so this is a post-reduction, post-pexy. You can see a good arterial endings, blood flow going to the right testicle. If you'll flip that around, you can just look at where my ultrasound probe is here. And
I know how to cut, I know how to sew, I know how to tie. Then COVID hits. How am I as a program director going to hire my next group of residents? I'm told I can't do in-person live interviews. So I start researching best practices out there. What are the best practices for corporations? Corporations have this figured out. We are like old school in some of our thoughts and things. So I began to investigate and we implement a one-way video interview as a screening device. We're going to be presenting this next week at Surgical Education Week.
Question number 2, why do you want to come to St. Joseph Hospital? This can be anywhere from I grew up in Denver to I want to live somewhere exciting to I have connections there. We just kind of like to get a sense of why people want to come to St. Joseph Hospital.
So I had to learn how to do virtual interviews. Fast forward 6 months, residency graduation, who would have ever thought we could have only a maximum number of people in one cohort? I love what Corey said they did. They went to a drive-in movie theater, and I'm kicking myself that I didn't think about that because I know the owner of a local drive-in movie theater in Denver. But we had this cohort of people all around Denver, and we sent food trucks to all the houses. And then at one point in time, my wife and I got in our car and we drove to where the chief residents were because I felt like it's really important that I personally hand them their graduation certificate. But we're forced into these situations where we have to be circumstantial learners. I became a COVID expert. This is one of my best friends. He ran an orphanage in India, probably one of the most humble people I've ever met in my entire life. He got COVID and went in the hospital, got really, really sick. So they're emailing and texting me his medication list. I'm talking with the experts. I'm constantly consuming COVID. And within a span of 24 hours, he died. So I became a real consummate COVID person. So you ask what I read and what my top 10 are, whatever I'm faced in life is what I learn about. Get a phone call, the one you don't want, that says your mom's been involved in a car crash. She's headed to the ER and there was a bone sticking out. So I cancel my plans and I go meet my mom in the ER. And this is actually the pictures that I took of my mom. I had to become an orthopedic surgeon. I had the first time ever operate on someone with an early obstruction after a gastric bypass. And when I got in there, they had a JJ obstruction. And when I got in there, I was confident that the 5 days post-op, she had eaten a bunch of chicken because this looks like chicken. She swore after surgery, I did not eat anything solid. I drank a Premier protein shake. 6 hours later, I decided to make a smoothie out of it. And I drank it. And then I came in and I was like, huh, what happens when you freeze Premier protein shake? So I go to Amazon.com and start reading reviews. I'm learning. And they say, the funniest thing, when you freeze it and thaw it out, it curdles, it clumps up. And if you look at the picture, she was drinking vanilla Premier protein shakes. So my learning is circumstantial. You have to learn in patterns. Sometimes there's nothing in the literature. I'm seeing a pattern of patients present with a very large retained fundus after sleeve gastrectomy. So you have to try to see, is there something out there? If there's something that's not out there, can I contribute to the literature so other people can read about my experience? I'll circle back around to this in the end when I actually get to my top 10. But this is a case that is very gratifying, but you hate it. So this patient had a sleeve gastrectomy. They were hypotensive and tachycardic, and I brought them back to the operating room.
Show me, guys. That's good.
It's not very often when you reoperate on these that you get that much gratification.
Good job,
of
Evan.
finding
Good
it.
diagnosis.
But this was a series of 3 or 4 of these.
Right.
And so I had to go and learn why are we having these complications? We take our residents to a PEG lab at the university. So we're teaching them all this really cool stuff. I walk outside and I have a ticket on my car. And I paid the bill. I went to the right zone. I paid the bill. So I began to learn about the local ordinances. I'm not going to pay an attorney $1,000 to get me out of a $60 ticket, but I sure as heck am not going to pay the $60 ticket. So I learned circumstantially. I learned what the rules were. ICG, this patient presented. This is a nightmare. Everyone looking at this will say, geez, that's probably an intracutaneous fistula. There's a piece of mesh in there. And if you think that, it's exactly what it is. My residents say, we get through this real tedious dissection. The fistula is stuck to everything. And they're like, let's give the patient some ICG. And we have this handy dandy device. And I'm like, okay, I don't think it's going to hurt anyone. I give it for my robotic gallbladders. I haven't really used it for this application. So what is that? So I began to read about ICG. I began to read about how we can do this. How can I apply this to my practice? My private practice is a little bit of a niche in complex bariatric revisions. This is what I did on YouTube somewhere. All right, so you can see the ICG here. The roux limb is here. The pouch is here. You can see the pouch is pretty well perfused. The roux limb is pretty well perfused. This is the second hit of ICG. When we do revisions, one of the things we worry about is devascularizing the pouch. This at least gives me some sense that the pouch is not devascularized. So now I'm going to get on to the meat of the talk. Now that you get a little bit of twist into my brain. So my number 10 paper is from what I would consider a toilet journal. We're in the process now of redoing our contracts with our surgeons. We're all employed by the hospitals. Most of us are salaried. We have nothing production in it, but I'm having a hard time getting my surgeons to do some of the academic things that they need to be doing. So I came across this, and it's actually a very good commentary on academic hybrid contracts. So you never know when you're right in the middle of something, something's going to pop up that's going to spark your interest. Just so happened, General Surgery News got delivered, and this was the headline. And I'm thinking, geez, we're looking at contracts. I've been talking with our legal department. Very well written. But more importantly in here, it gets me contact information so that I can get a hold of subject matter experts who have navigated this. And I don't have to make that up. When we look at articles, much to Sean's point, you got to pick out what's applicable to you, but don't be so hesitant to just poo-poo it. My number 9, if you take this as like, this is a scientifically valid paper, this paper is monumental. I really want to say, when I look at literature, I try to look at it from the 70,000 foot view. So my residents are pushing me to go use this ICG. They want us to get all these high-tech 4K cameras. We got this handheld thing, but I want to know, like, what is the data about this now? Because I can take the data and twist it into anything that I want to twist it into. Is there some validity to my thought and my thinking? Hey, this stuff might work. My anastomosis looks like it's got blood flow going to it, but is there science to back that up? So you go and you start looking for papers, maybe to support my position, but really not to support it, but for me to say, is it safe? What does the preliminary data show? Is it worth the capital investment? Can we have some research from it? Can we do some work with it? So let's say number 9 for me is ICG. How do we apply that in general surgery? How do we apply that to our practices? Is there something there? Or am I such an old cooter that I'm not willing to go out on a limb and try something new that may have some impact? Number 8, this circles back to my GERD after sleeve. So I'm seeing this and I'm looking for literature. There's a little bit, but there's not a lot of it. Like, you know, we know it happens. We know that people get GERD after sleeves. But when I'm talking to my patients, I'm using the MBSA QIP risk calculator, and that tells me GERD should go down, but I'm not quite seeing that in my sleeve patients. So maybe it gives me the opportunity to contribute to the literature when I can't find literature that kind of helps guide my clinical decision-making. Number 7, and I don't want to make a lot out of COVID, but being a surgical educator, it really bothered me when COVID happened because I knew it was going to hit our residents. It was going to impact them. Nobody really knew how it was going to impact them, but it is. And so what does the literature say on that? What have people done? What have they done to try to improve morale? Little did I know that the downstream effects of COVID was going to shut my OR down again for 6 weeks at the beginning of this year because we didn't have enough people in SPD. So we went from full bore down to less than 40% of cases for almost 2 months of Erica Poulis's chief year. And we don't get a lot of understanding from the board or the ACGME now because we're past COVID, but this is an absolute effect of COVID because we can't get staffing. So it's really important that we keep up with what is the literature saying and how does this impact our trainees. We got a citation from the ACGME because the residents felt like we needed to give them better feedback. Little did I know when that survey went out, our end of rotation evaluation system had stopped sending out evaluations for 6 months. Nobody bothered to say anything. Nobody knew it. It was a glitch in the software. So the residents are thinking, geez, you know, the feedback. So I started reading on feedback and what is feedback? And yeah, we got to do an end of rotation evaluation, but what is that good? What you find in resident education is it's better to do end of operation assessments and let that paint how the progress of a resident's doing. For my program directors in here, I think we all agree that it is probably not the best to take an end of rotation evaluation. That provides too much room for narratives, whether a positive narrative or negative narrative. So I continue to look at, hey, what is this operative narrative feedback? What is this? How do we do the end of rotation evaluations? Is there some validity that maybe we have a better way of evaluating our residents? And I think a lot of the thought leaders now would say probably end of rotation evaluation is the least effective way to evaluate residents. So again, I got a ding from the ACGME, which then put me in a circumstance where I had to go look at stuff and I had to go try to figure it out and make heads or tails out of it. This is an email, and just bear with me for a minute. This is from one of my ER docs. And basically, I'll read this. All this is to say, I couldn't include the whole thing, but all this is to say, it seems awfully paternalistic of us to shuttle everyone with appendicitis down the surgical path when many might prefer an attempt non-surgical option. So here I have an ER doc that wants to implement this new protocol like overnight on non-surgical treatment of appendicitis, and he hasn't thought about all the downstream effects. And so we were in this bantering back and forth, and this is what he quotes to me. This is the American College of Surgeons statement on COVID-19, and I would contend this was written to say, yeah, it's probably safe, but you need to be real careful about who you don't do appendectomies on. But he's trying to quote this as saying the American College of Surgeons says that the first line treatment is non-operative management. And so I went to my residents, and Erica knows because I sent this email to them and said, what do you guys think? Went to my partners and said, what do you guys think? Went to another general surgery group and said, what do you guys think? And the overwhelming majority of people said, we think the surgeon should be the one talking to the patients. But this came from a New England journal. This was an update to the CODA trial. This is literally, there's no abstract to it. It's an update. They suggest that we need to show the patient a 30-minute video on this. Now, I asked him, I said, now you're trying to get patients out of the emergency department. You're trying to get them out. You're going to keep them there for 30 minutes. Who's going to show them the video? Who's going to do a test to make sure they understand the video? Who's going to call these patients the next day to make sure they're doing okay? And these were all the questions we couldn't get answered. So again, I had to become a circumstantial learner on appendicitis because most of those things I just let go in one area and out the other. This is such a high stakes game that I thought patient outcomes could be adversely affected if we tried to do this and the system around it wouldn't support it. So I became a circumstantial learner. I think it's really important that we have these conversations about appendicitis. I think it's really important. I think it's important that we don't put our head in the sand and say, I will never manage appendicitis with just antibiotics, because the data says there's a subset where we probably can. So we can't be too staunch about it, but I think we have to be a little bit thoughtful about the systems. My number 4 and the next few are from this conference. And I picked them for very intentional reasons. So we have a level 3 trauma center. I happen to be the trauma medical director. And these are my data on here. The number 1 mechanism of injury is fall from standing in the elderly patient. So the scientific validity of this paper, Emergency Medicine Can Safely Manage Geriatric Trauma Patients, the scientific validity of that, I don't know if it's scientifically valid, but what it shows me is there are hospitals, there are systems out there that are putting things in place that might be able to do it better than we're doing it. Can we take that and replicate that? Can we pilfer from it? Can we take and apply? Because this is applicable to my patient population. This morning I had a trauma committee meeting and we're talking about this stuff. We're talking about our elderly falls that get pelvic fractures. This is exactly, can we make it better? Think as you are a surgeon, you're going to come across things that are very, very applicable. That's the value of these conferences, is that you get to hear stuff that's going on out there before it gets in the press, before it gets out there. My number 3, routine preoperative COVID testing and elective surgeries. Is it worth it? I put an email from my partner. She's my colorectal surgery partner. She was very frustrated because we have a new policy in our OR, but endoscopy was just knee-jerk ordering COVID tests on anyone who wasn't vaccinated because it made them feel good. So when I see this, now I can think it through and I can go back and I can do a cost analysis. And I can show our hospital system, this is how much we paid, this is how many positive results we have. Because none of us want to delay our cases, especially in colonoscopies. Here you have a patient that comes in who's fully prepped. And we also know that they could have had COVID a month ago and they're going to be positive. So again, it's really important that you take what you hear and apply it to your everyday practice. Number two, and this is going to get a little bit personal and I'm okay with it. The mental health arena around surgeons is so underdeveloped and so underappreciated. I show this event, this was August 1st, 2006. I've been out of fellowship a year. I'm a junior attending, and all of a sudden I get a busload full of Iraqi army people and 50 burn patients show up in the ER, and everyone's looking to me for answers. I had a vascular surgeon and me, and he's like, I don't know what I'm doing. They're looking to me for answers, and I really don't have a lot of guidelines. So at the end of that day, I wrote a morphine drip for 6 patients who were burned 95% of their body. The gravity of that is huge, but I had to stuff it deep down inside because I had to go on, because I'm gonna have some person blown up in three hours. Fast forward to 2019, 13 years later, I get in Djibouti and all of a sudden weird stuff starts going through my brain. I start having panic attacks, and I've never had panic attacks. I start having nightmares, never had nightmares. I blame it on the Malarone that we had to take there for malaria, but this kept going on. And over the next 6 months, I spent time with a psychologist unraveling the PTSD that I had from this event that happened. So when I come and I see people talking about responses to patient loss, that's huge for me. 3 weeks ago, I get the phone call no program director wants to get, but thank God it wasn't that phone call. And the conversation went like this. And I was at the horse stable. My kids were riding horses. It goes like this: Dr. Johnson, I need you to get in private. I have something I need to tell you, and it's very important. You need to drop what you're doing, and I need to have your undivided attention. You don't need to have any distractions. And I'm thinking, good, is the sky falling? And over the next 10 minutes, I come to find out that one of my interns is suicidal and has a step-by-step plan to execute the death by suicide. Mental health among us needs to be a priority. We all are stuffers because we go to the next thing, but it can come back and bite you. So when I see this, I think it's really, really, really important. The scientific validity, I really don't care about that. But what I like is that we're talking about it. I like that Kotari can come talk about near-death experiences, can talk about how much his family means to him, get teary-eyed, and everyone's like, that's me. I can talk about PTSD. That's me. Take it or leave it. I remember when COVID started, I stood at our command center, and there was a room of about 400 people, no, about 200 people, and they were like, we're gonna have COVID, we're gonna start shutting things down. And I raised my hand as the only person in the back of the room, and I said, I want to stand on record to say the mental health component of this cannot be underestimated, because people are gonna see things that they're not supposed to see, and it can affect you in ways that you have no clue how it's gonna affect you. And I think as surgeons, we're prone to that. We still have a problem in our ranks of death by suicide. This is my number one. It's called The Infinite Game. It's a book by Simon Sinek. Again, I don't read. I read, but it's actually I listen. This has taught me more about being a leader and thinking beyond the metrics, but thinking like to next month, next year. What are the decisions that I make today? How are that going to impact my organization in 6 months, in a year? Because if I'm making decisions that just face today, then I'm missing an opportunity. And I have a second number one. I'm bearing my soul here. My medical director of our bariatric program does not know that I'm showing this, but I really don't care because he works for me, sort of. I think if I could distill down as surgeons, the single most important thing you can read is your outcomes. And so you talk about what's my top 10, this will always land at my number one. If you don't have time to read, you should take time to read one thing. and you need to read about your outcomes, because I will never contribute a Sentinel article to the literature that's going to change practice. I've already come to terms with that. That's not how my brain works. My ADHD can't keep me focused on one project more than about 5 minutes. But what I can do is I can take my data, my institution's data, and I can make the care that I deliver to my patients better. So of all the things I discipline myself to read, it's this document along with our NSQIP data. Because as a leader, as a program director, I teach the residents, you guys aren't going to make this big paper that's going to change practice, but what you can do is you can learn how to deliver care better where you are. And without the data and without reading the data, you won't ever be able to make a big impact. So I think this will always be my number one thing that every surgeon should read. It's not a scientific article, but it's something that can change your practice and can help patient outcomes. And I want to say thank you all for listening to my top 10.
That was it. Is this one on? Yeah, that was an excellent way to end the program. Thank you very much. So that ends it for this year. Thank you, Dr. Kathorian. Thank you, Dr. Grover, for a great program. Enjoyed everything and enjoyed everybody coming here. And thank you for all your participation and discussion of the paper. So next year, Ojai Valley, April 16th to the 19th. We'll see y'all there.